we've been talking a lot about clopidogrel, and one thing that we need to remember is that clopidogrel actually isn't an active drug. It requires conversion in the liver to an active metabolite before it can work and to inhibit the P2Y12 receptor. And that conversion happens through cytochrome P450. And one of the key polymorphisms that's common, with variation that's common, is in the CYP2C19 gene. And that there's a loss of function alleles. So in other words, an allele where clopidogrel can't be converted to its active form that are frequent and present in 15 to 60%, particularly in Asian ancestry folks, where that number is as high as 60%. So does that matter? Well, in the CHANCE trial, they looked at that in a very large study and found that those who did not convert or wouldn't be expected to convert clopidogrel, the carriers of loss of function alleles, aspirin and clopidogrel showed very similar effect on stroke risk after stroke and TIA. So in other words, if you don't convert clopidogrel, it doesn't work. And then they found a very large effect in those who did convert clopidogrel based on this, again, the CYP2C19 loss of function alleles. And it's not just in that trial. That effect has been seen in several other studies where if you treat with clopidogrel after a stroke or TIA, loss of function, people with loss of function alleles tend to have higher stroke risk than those without them. So this is one meta-analysis that was done again by the TN10 group. There's the potential advantage for ticagrelor. It acts directly on the receptor, and maybe the variability, but people appear to be more similar as far as we know in terms of their benefits from ticagrelor. In the PRINCE trial, actually tried to take a look at this and ask the question, in patients with acute stroke or TIA treated with aspirin, does ticagrelor inhibit platelet activation better than clopidogrel, particularly in those with the CYP2C19 loss of function? So it's a randomized, unblinded phase 2 trial. And the outcome was looking at, do platelets continue to react at 90 days? That was the primary outcome. Relatively small trial, 675 patients, all in China. And what they found was that, so high platelet reactivity, so meaning residual platelet reactivity, was present more frequently in those receiving clopidogrel than those receiving ticagrelor at 7 and 90 days. Now this is without looking at differences in loss of function alleles. So just overall, ticagrelor worked better. But then that effect was greater in those with the polymorphisms that you wouldn't expect to benefit from clopidogrel. So, a sort of graded response, but still some residual response in those in whom you would expect clopidogrel to work. So consistent, but also suggesting that ticagrelor's benefit might not just be limited to this difference in CYP2C19 function. The other thing that we found in these prior studies that we've heard about before is from the forest plot of the Socrates trial. So remember, Socrates is ticagrelor versus aspirin, head-to-head, no background aspirin. In the forest plot, we noticed that those who received aspirin therapy tended to benefit more from ticagrelor. So these effectively were patients getting ticagrelor aspirin versus aspirin. And so that suggested, well, maybe that's the trial we should have done, ticagrelor aspirin versus aspirin. And that was part of the rationale that got us to the TALIS trial. So now I'm going to talk for a while about the TALIS trial. So the purpose of this trial was to ask a question in patients with acute, mild to moderate. So we included some more severe strokes in this one. Ischemic stroke or TIA, is dual antiplatelet therapy with ticagrelor and aspirin superior to aspirin alone in preventing subsequent stroke or death? So a composite of those two. Double-blind, placebo-controlled, randomized trial, very large international trial. And the entry criteria is similar to what has already been discussed for POINT and CHANCE and Socrates. Differences are that we included NIH stroke scale scores of 4 and 5. Those hadn't been included before, so some moderate strokes. Ended up being 30% of the population, so an important subgroup of the population. And only the most severe stroke, TIAs by ABCD squared score, but also those with symptomatic arterial disease, because that ended up being important in the other trials. And randomized to ticagrelor aspirin versus placebo aspirin, in standard dose of ticagrelor with a small load, standard dose of aspirin. And the endpoints, that composite of ischemic versus and hemorrhagic stroke or death, and then secondary hierarchically tested time to first occurrence of ischemic stroke, or also we looked at disability in the overall population. The primary safety outcome was severe stroke by the Gusto, or severe bleeding by the Gusto definition. And then we also had an exploratory endpoint of disabling of the stroke. A priori defined, but I'm going to show you that today because I think it's important to see that data. The groups were quite similar in those randomized to ticagrelor and placebo. And what we saw was that ticagrelor worked. So ticagrelor aspirin was superior to placebo in reducing the primary outcome. The hazard ratio is 0.83 and the p-value 0.015. So a real impact. You can see that most of that was stroke, no difference really in death between the two groups. Stroke dominated in terms of the outcome. The absolute reduction was 1.1% in strokes, again, over this 30-day period. For ischemic stroke, the difference was even a little larger, so hazard ratio 0.79, 0.004 was p-value. And then looking at disability, overall disability was similar between the two groups. So no difference in that. It ended up being dominated by disability that happened before randomization. So because there were 4s and 5, NIH stroke scores 4s and 5s in this, there was a fair amount of disability in both groups that period of study. So we probably shouldn't have expected to see a difference here. But we did see a difference in the portion of people with disabling strokes in the two groups. So ticagrelor aspirin did appear in this, a priori defined exploratory analysis did reduce disabling stroke. And that reduction of disabling stroke, so this is overall stroke, this is a disabling stroke of 2 MRS scored of 2 or greater, 3 or greater, et cetera. It happened, regardless of where pretty much regardless of where you set the cut point, except for in the very, very severe strokes. And the ordinal shift was also significant. Taking a step back, looking at primary outcome by subgroup, it ends up the subgroups were quite similar across the board. There really were no significant differences by subgroup. But this benefit did come at the cost of severe hemorrhage. So hazard ratio of 3.99 and highly significant. But the absolute rates were quite small, 0.5% versus 0.1%. So again, it's tiny, about a third of what we saw for the reduction in ischemic events. Most of that severe bleeding was intracranial hemorrhage or fatal bleeding. So these are all inclusive of each other, so they're not, you shouldn't add them together. And most of that was from intracranial hemorrhage. About half of that was from hemorrhagic stroke. So some of those are conversions of ischemic strokes. And moderate to severe bleeding was also greater in ticagrelor. So in general, for ticagrelor aspirin versus aspirin, it works, it's better, but it comes at a cost of hemorrhage, as one expects, as was seen in point. So what about head-to-head data? Well, we have an ongoing trial right now, really, really important, that's going to look at ticagrelor aspirin versus clopidogrel aspirin. It's a 3-month trial looking at stroke as a primary outcome, initiated within 24 hours. years. And it's just looking at the loss of function group. So that a group with CYP2C19 who you wouldn't expect to be able to convert very well anyway, clopidogrel to its active form. So the group that we think should be benefiting more from ticagrelor. It was just launched, but it's already about half enrolled in a double-blind randomized trial, pretty large, but is it large enough? I don't know, but it'd be nice to have this important head-to-head data, particularly in that genetic subgroup that matters so much. So where are we today? Clear and easy recommendations are dual antiplatelet therapy as soon as possible for everyone. Yes, you can treat out to 24 hours and probably even later, even though not shown in trials. Makes sense that it would work out later, but it's going to benefit people more if you treat them earlier, just because you have longer time to prevent the high-risk events. And then for 21 to 30 days, that seems to be the right range from secondary analyses and from the trials that we have. Less clear is a choice between clopidogrel and ticagrelor. So it's a balance between these two. So for clopidogrel, we definitely have more data. There's more trials of clopidogrel and aspirin together. It's cheaper and it's daily drug. For ticagrelor, no genetic variability. And for certain populations, that's probably going to matter. They're really uncomfortable with genetic variability. FDA is uncomfortable with it, but in particular groups of Asian ancestry, that's going to be even more relevant, most likely. And it's proven for moderate stroke. That is not the case for clopidogrel. And there's some theoretical benefits as well in terms of efficacy, as we saw from the Prince trial. So NIH strokes go 4s and 5s too probably makes sense for ticagrelor. So in conclusion, the key is to get patients on dual antiplatelet therapy as soon as possible, as much as possible within 24 hours after high-risk TIA or mild to moderate ischemic stroke. That's not happening enough, needs to happen more. You've got more than one choice of agent to use alongside of aspirin. Should treat for 21 to 30 days. That seems to be reasonable, long enough. But which you use is really, I'd say, dealer's choice at this point. I think there's not strong data recommending one versus the other, and there's specific instances where one may be preferred. And I've heard opinions about both ends of that range. I'm going to only use clopidogrel because there's more data and it's cheaper, and people who've said I'm going to only use ticagrelor because they're uncomfortable with genetic variability that's not necessarily known. And so why not treat with an agent that always works? I don't believe either of those and was involved in both trials. So I think it's right now it's going to be thinking about which makes most sense for you locally and for specific patients. And then chance 2 is going to be critical to providing key evidence to choose between those 2 agents. So thank you all for your attention. It's now my pleasure to.
Okay, thank you everyone. So I think it's time for